Coming to the second video in the series of lectures for breast under general surgery. In this video, we're going to discuss about the different surgical aspects, the complications of the surgery, and the chemotherapy and the radiotherapy that needs to be given in a patient of CA breast. Okay. First, coming to the surgery for carcinoma of breast. For surgery, you are having two options: mastectomy versus breast conservation surgery. That is mastectomy versus BCS. You have to remember, in both these procedures, the overall survival rate is the same. How the local recurrence rates are more with BCS, okay, breast conservation surgery. And also one thing is important, that radiotherapy is compulsory after BCS. Like post mastectomy, she might or might not need radiotherapy, but if a female undergoes BCS, then radiotherapy is compulsory. BCS is also known as lumpectomy, that we are just removing the lump, the breast lump the patient presented with. The margin that we keep is 1 millimeter. Like if this is the breast and if this is the lump, then we remove this part of the breast, keeping a margin of 1 millimeter. Earlier this was 1 centimeter, which has been reduced to 1 millimeter. What are the contraindications of breast conservation surgery? Absolute contraindications are pregnancy or a multicentric disease. Very easily you can remember this, that in pregnancy you can't give radiotherapy, right? If you can't give radiotherapy, then BCS can't be done. Hence pregnancy is a contraindication. Multicentric disease means if this is the breast, I've already taught in the previous lecture, if this is the breast and if one lump is in one quadrant, second lump is in the other quadrant, and the distance is more than 5 centimeters, then it's called a multicentric disease. For also this, you can't just remove one lump, okay? You need to remove the entire breast tissue. What are the relative contraindications of breast conservation surgery? Collagen vascular diseases like rheumatoid arthritis or a SLE, prior chest radiation, lobular carcinoma. In lobular carcinoma, you have to remember that if the lobes are involved in cancer, then you will have to go for mastectomy. Locally advanced carcinoma or a large tumor to breast ratio. If the breast tissue is this much, and if the lump is this much, then you can't just simply go for a BCS, you will have to go for a mastectomy. Coming to mastectomy, you will have to remember 3 types of mastectomy. One is simple, one is radical, one is modified radical. In simple mastectomy, you will have to remember that we are not removing any lymph nodes, okay? No lymph nodes are removed. The breast, nipple areolar complex and the pectoralis fascia is removed. This is done in case of phyllodes tumor or a fungating mass, or in cases of DCS. Phyllodes tumor is a benign condition in which we remove only the breast and nipple areolar complex along with the pectoralis fascia. No need of removing the lymph nodes in this. Okay. Radical, or it is also called a Halsted mastectomy. Here we remove everything. Just remember everything: breast, nipple areolar complex, pectoralis major and minor, with lymph node stations 1, 2 and 3. In modified radical, we give a Stewart's incision. It is an elliptical incision. Okay, if this is the breast tissue, then we give an elliptical incision and Stewart's incision. What do we remove? We remove the breast, nipple areolar complex, pectoralis fascia, 1, 2, 3 levels of lymph nodes, and based on pectoral minus, it can be retracted or it can be cut. If it is retracted, just it is called Auchincloss. If it is cut, then scalon and pete, right? You need to remember that in modified radical, we are not touching, like we are not doing anything with the pectoralis major muscle, lateral and medial pectoral nerves. All these things are spared in modified radical mastectomy. See, this slide is very important from MCQ point of view and also for your final year exams. What are the complications post modified radical mastectomy? The number one and most common complication is seroma formation, that is fluid accumulation beneath. For this, usually during the OT procedure, we put drains, usually 2 drains, mostly a Romovac drain, right? And we remove the drains if the output is less than 40 ml for 2 consecutive days. Important thing to remember, if there is accidental removal, then we don't usually reinsert it. Conservative management we do. And also one important thing is that alternate days sterile dressing is important. See, dressing is not only about the skin dressing that we do. During dressing, we also milk from the along the and perpendicular to the line of incision, and we remove any collection if it is there. Then we just milk it, right? That helps in decreasing the chances of seroma formation. Second is hemorrhage. That is also true with each and every surgery that we do. Third is a nerve injury. These are very important from the MCQ point of view also. usually get a question that which is the most common nerve injured, and what are the symptoms of this what are the symptoms that the patient can have if those nerves are injured. Okay, most common nerve injury is the ICBN, intercostobrachial nerve, which supplies the which has the sensory supply to the breast. Second is the long thoracic nerve. We all know this nerve supplies the serratus anterior, and if it is involved, it can cause winging of scapula. Thoracodorsal nerve, it supplies the latissimus dorsi. The dorsi and dorsal, you can identify like this. Lateral and medial pectoral nerve supplies the pectoralis minor and the major muscles. There can be flap necrosis. There can be lymphedema. Lymphedema means how the patient presents is there is swelling of the of that side of limb, upper limb mostly, where there has been axillary lymph node dissections. Okay, and very important thing is that most common cause of upper limb lymphedema is MRM. Okay, incidence is 2 to 10% in post MRM cases, and there is increased risk if there are lymph node removal or infection of the upper limb. Care has to be taken that no needle pricks are there, no BP measurement is there from that ipsilateral upper limb, and compressive stocking can be used for this. Same goes in cases of if we are preparing any patient of CKD for AV fistula. Okay, for AV fistula creation, then also we want that there should not be any needle mass, no BP measurement, because these all things creates a venous thrombosis. Okay, and see, in AV fistula what we do anastomosis between the artery and the venous of the upper limb, mostly of the upper limb. So we need to preserve the veins nicely, hence this BP measurements and the needle prick should be avoided in those cases also. Long-standing lymphedema causes angiosarcoma, lymphangiosarcoma, which is known as the Stewart syndrome. This question has been asked many a times. Okay, what is this image shows? It's image of Stewart-Treves syndromes, and if there is a patient of Stewart-Treves syndromes, the patient will be needing sorry, a 4-quarter amputation with chemotherapy, and this usually has a very poor prognosis. There is something called phantom breast syndrome, which is most commonly with ICBN neuralgia, and the reason of which is regeneration of the nerve. Now coming to the lymph node removal, what you can do, you can remove all the lymph nodes. However, this increases the risk of lymphedema. Or you can go and selectively remove those lymph nodes which are involved, like in the cases of sentinel lymph node biopsy, right? What is a sentinel lymph node? The first draining lymph node is the sentinel lymph node. It was first described by Cabana for penile cancer, okay? And it is also used in head and neck carcinomas, penile carcinoma, and malignant melanoma. In these 3 kind of malignancies, sentinel lymph node biopsy comes into act. What are the indications of sentinel lymph node biopsy? That clinically patient should be N0. If the patient is already N1 or not, like N2 anything, if the nodes are clinically palpable, then there is no point of going for a sentinel lymph node biopsy. You can just take a direct biopsy of it and send the lymph node for histopathology or a malignant cytology. What are the different methods of sentinel lymph node biopsy? Blue dye technique is there. Radionucleotide method with technetium-99. Best is this combined method 1 and 2, in which you combine blue dye technique with the radionucleotide method. Blue dye technique is the most commonly used. Okay. And new thing is that Centimag, in which ferrous oxide injections are used, and a magnetic scanner is used. This has decreased radiation exposure. Okay, in this you see that we just inject this blue dye near the lump, mostly near the NAC. We usually inject it near the nipple areolar complex, and whichever lymph node is involved first, that will appear blue, and we take a biopsy of it and send it for frozen section. What frozen section does? Frozen section gives the report in 30 minutes if it is positive or negative for malignant cells. This everything is done on table. Okay, this is not done in post-op or pre-op. This everything sentinel lymph node biopsy is done on table. What are the complications of sentinel lymph node biopsy? Same as MRM. The most common nerve injuries that can occur is for that ICBN. There can be skin tattooing if blue dye technique has been used, and because of the dye, anaphylaxis can occur. Okay, mostly level 1 lymph nodes are involved. Like when we do a sentinel lymph node biopsy, mostly 11 lymph nodes are involved. And one important thing is that most are more than one sentinel lymph nodes. Okay, it's not like it's draining into only one. Okay, so you will always find that more than one lymph nodes are involved, and we usually get to remove like 3 to 4 lymph nodes after sentinel lymph node biopsy. Coming to the reconstruction post MRM, you have two options, TRAM and DIP. Remember, इसमें TRAM में M है, which stands for the muscle. And the picture you can clearly see him, TRAM versus DIP. TRAM में transverse rectus abdominis muscle flap. You remove the lower abdominal skin with fat, and one of the rectus muscle is usually used for a flap. In the DIP, that stands for the deep inferior epigastric perforator flap. Here the skin is used, fat is used, but it spares the rectus muscle. In the TRAM flat, rectus abdominis is used. In the DIP, no rectus muscle is used. Chemotherapy, what are the chemotherapeutic agents that we give now? Is the 4-AC EC with 4T. What does A stands for? Adriamycin. Okay. E for epiribicin. And C for cyclophosphamide. Okay. So you can give 4 cycles of AC or EC with 4T. T are the taxanes groups. Example is the paclitaxel. Important side effect is the tremors. So you need to be careful with females who are musicians and all. Then paclitaxel should be avoided. The introduction of chemotherapy is usually through a chemoport, which can be used for 4 to 5 years. Now, one very important thing, आप किसी भी ब्रेस्ट कैंसर सर्जरी वाले पेशेंट को आप पूछोगे, ब्रेस्ट कैंसर वाले पेशेंट को पूछोगे कि विच हैज़ बिन द मोस्ट हेक्टिक एंड विच हैज़ बिन द वर्स्ट एक्सपीरियंस फॉर हर ड्यूरिंग दिस ट्रीटमेंट कोर्स, तो मोस्टली वो फीमेल बोलेंगे कि केमोथेरेपी वाला जो पार्ट था दैट हैज़ बिन रियली बैड फॉर हर. ओके, तो देयर इज समथिंग कॉल्ड अ मॉलिक्यूलर टेस्ट फॉर कीमोथेरेपी. ये हम लोग को बताता है कि वो फीमेल को कोई फ़ायदा होगा, विल दैट फीमेल बी बेनिफिटेड विद कीमोथेरेपी, और इफ द फीमेल can take chemotherapy. Okay, and if these tests come negative, then there is no point of giving chemotherapy to that patient. These tests are very expensive, and these are only done in selective centers. Okay, these are very expensive tests. You just have to remember the name of this test. One is MammaPrint, Oncotype, EndoPredict, and PAM50. This is the image of a chemoport that has been introduced here. The port is usually kept at the subcutaneous space, and this part, it goes into the subclavian vein, into the SVC. This is how we connect a chemotherapy agent to the chemoport. This human needle point, it goes here, and this end is connected to the chemotherapy agent. Coming to radiotherapy, what are the indications of giving radiotherapy to a CA breast patient? If the patient is post BCS, I have already told you BCS होगा तो radiotherapy देना ही है. If the patient is positive for lymph nodes, any lump which is more than 5 cm in size, or a locally advanced carcinomas. Okay, two methods of giving radiotherapy, conventional versus ABPI. Conventional means the whole breast is irradiated with the radiation. Okay, the course is for 25 days, occurs single sitting per day, and 50 to 54 GY is the radiation exposure. ABPI means all partial breast radiation, that only selective parts of the breast which are close to the lump are irradiated. It is usually a 5 days का course होता है. 2 sittings per day we can give, and the radiation exposure is 30 to 35 GY. The important thing is that here in ABPI we just give selective parts more radiation, right? So hence the local effects will be more with ABPI. Coming to the hormonal therapy में, if the patient is premenopausal or postmenopausal, depends upon that we give the hormonal agents. If it is a premenopausal, then you have to remember that we need to block both the ovary and adipose in order to reduce the estrogen. If we need to block both ovary and adipose, we use SERM. What does SERM stands for? Selective estrogen receptor modifier. Okay, examples of this are tamoxifen or raloxifene. If we use this, then it can cause a plethora of symptoms which are similar to that of a menopause. Like a hot flushes, or we have seen that there is increased risk of thromboembolism in these patients. If the patient is postmenopausal, then the ovaries are already devoid of any ovarian follicles. Then we just need to block the adipose tissue. Here we use the aromatase inhibitor like a letrozole, which can increase the risk of osteoporosis. Coming to the metastatic CA breast, if the cancer has already reached the stage of M1, the only option available to us is the palliative treatment. These two sentences are very important. What is the most important prognostic factor for a case of CA breast? Then it is the lymph node status. But for a M1 cancer, the ER and PR status is the most important prognostic factor. Okay, just one term that you have to remember: no visceral crisis. That if mets are present but there is no symptoms of any other organ involvement, then this entire thing is called a no visceral crisis. Okay, I've already described that most common site of mets are the lumbar vertebra, and for mets you need a PET CT scan.